I present this bill to you after a half a decade of hard work with stakeholders across the board when we talk about mental health intervention, from law enforcement to mental health providers, even today, discussing what it looks like to be in crisis mode. We do know we've worked very hard, the state legislature, to really look at providing services after the individual is in the system, working through the process of what we call a crisis situation. But the initial contact is usually done because there's some kind of behavioral issue that's occurring. There is something that has happened, and 911 has been called, or 988, and there is a crisis. So law enforcement responds to stabilize the situation, and at that time, we do have pilot projects where mental health providers ride with law enforcement. After extensive stakeholder conversations, we learned some of the best treatment when it comes to that crisis situation, whether that is suicide, a psychosis, or whatever situation that individual is in that moment, in that crisis mode. It was best to have law enforcement respond and stabilize the situation, but have mental health come in separately, so they're not riding together. So you don't have that one car situation. And when the mental health provider responds, they're able to really stabilize the situation, understand what the individual is going through and whatever that crisis mode may be, and then work to getting that individual in the system to receive continuous care help. So this is the first line of defense when we talk about that initial crisis mode, really where you see some of the saddest moments of an individual's life. And to have an initial response by a mental health provider is life-saving and life-changing, including saving family situations and saving lives. And it's from juveniles all the way up. So this bill has been worked on, like I said, half a decade through all our stakeholders to really look at what was the best situation. And I know I have the Emergency Management Division come up. This bill was modeled after Oregon's CAHOOTS model, which after many years with legislators that have gone to the other side, the Senate, and many meetings, we've learned that that name is not the best. We like our name. So working together and seeing what that initial response is to really save that individual, that family, that network in that crisis mode would be to have this mental health response team there on site and in present. And why it's two separate pilot projects, just to fully define. So my district in rural areas has some of the highest suicide rates in the state of Washington, some of the highest crisis situations that are responding, and don't have the mental health providers that can come. Sometimes they can come on Tuesdays if they come from the urban areas, and that would be if you make an appointment and maybe you can do telehealth. We are really in what we call a crisis mode situation when that person needs that help immediately, and there's no one there to respond. And so we have mental health deserts in a lot of areas of the state. And really looking at having this pilot project will really show when we are having people, and like I said, one of the most difficult times in their life, that they are able to respond and assist in that scenario is some of the most important things we can do. I will mention that we have had a hard 2 years in our communities. And I think we all have in all our districts, but really seeing it in our youth, it would be nice to have some initial response and not being told by our communities that, you know, you can get help in 2 weeks. You can get help when there's an appointment in Spokane or another area. And you've really seen a struggling of our youth and some of the high suicide rates. And I would really like to make sure that they have the help that they need when those crises occur. I'm happy to answer any questions.
Oh, thank you. I was going to ask you that, Representative Fultz.
Yep, thank you, Madam Chair, and thank you for bringing this bill forward. So maybe a couple parts to this. So this is a pilot project. So what's your long-term vision? Like, let's say if this is successful, where do you see it going? And maybe touch on, it sounds like Oregon might be a little bit ahead of us in this space. So if you could just kind of touch on both those.
Thank you for
please.
that question. Yes. So what we'd really like to see is when law enforcement has stabilized the situation, they really need to go to that other call, right? And so that mental health provider comes in and provides that stability of the situation, that de-escalation, that initial response that either gets that individual to help right away or has those services wrapped around where they get that contact. It's not just a phone number, call this on Monday and maybe you can get an appointment. It's you're in the system, we're here to help, and there's people that are going to come together to make sure you receive that help. So making sure that we have those initial response around the state of Washington is ideal, right? Because we talk about mental health as this, one of our top priorities. And as you know, in the bienniums, we've made it our top priority that we have mental health providers and assistants and somebody there. But that initial contact is what saves lives. That initial contact is what gets people the help they need. Because 1-800 number that you can call on a Monday morning at 8 is not where people seek assistance. It's when they're late at night and they need the help the most. And so having that access across the state of Washington and saving lives no matter where you live, you have an equal and equitable access to somebody there to stabilize the situation in your mental health is what we should all expect from the state.
So I think you kind of answered my co-responder team question, that not the same vehicle, separate vehicles.
Yes, separate vehicles. It took 2 years of stakeholder agreement to really talk about what's working in other areas and what's not working. And what we came up with, and this is a large group of stakeholders, what we came up with is that the separate cars worked best, especially when law enforcement, if they had another emergency call, you really don't want to leave that individual, right? And the mental health provider would have to stay in the car if they're assigned to that vehicle. So if there was an emergency call, they found that it was difficult to pull that mental health provider from that situation and respond to that emergency call. The 2 separate vehicles have worked best in the state of Washington.
So the question going, not from this committee, but the next stop that you're going to make is going to be, can't we do that with the current co-responder team? So just be aware, that's the kind of question we will be asking. And then the other 2 modes that I am aware of are regional mobile crisis teams, and then the crisis teams that are dispatched by 988. I mean, it's not for you, I mean, you probably know the answer, but it's more for the
You know the answer.
Okay, good.
And I would love to talk about it. So this bill was prior to 988, and now that 988 is integrated, we keep talking about this situation, but we haven't integrated into implementation. And that's the frustration that I think a lot of my communities are having. They're having, okay, well, we talked about this. This bill was dropped, repeatedly over the bienniums with stakeholder agreement. Why are we not seeing some kind of access to these rural areas? And really when our communities that are suffering the most, and we are. It's the children in tribal areas that have really, really suffered, and you can look at the numbers, or are in crisis mode the most. And why are we not seeing somebody on the ground? Under the Emergency Management Division, they run. The reason that and he'll explain, testimony will explain, the reason they run that system is because they run the Amber Alerts, they run 911, they do that wraparound service, so they're the best avenue. And other states, this is the best situation that has worked in other states and been successful in implementation.
So is that the same problem with the regional mobile crisis teams, that it's not quite getting to, probably because in the Puget Sound area, we also still have outstanding needs. And so is that the problem with the regional mobile crisis team, that it's not getting to your district?
I haven't even seen it, unfortunately.
All right.
Thank you, Chair. But I mean, I can look into it, but it has not seen it in my district. I would love to see this go out to our areas.
Great. Thank you. Any other questions of the prime sponsor? This is your time to grill. Yes, Representative Brill.
Chair, you don't grill too much.
Thank you, Madam Chair. In the time that you've been working on this, have you been able to ascertain some of the similarities or differences between the needs in the rural areas and the urban areas, and how does this bill speak to that?
Thank you. Oh, I really appreciate that question. Yes, and you have rural areas in your district, absolutely. That initial response, in my understanding, and this is just from stakeholder meetings, it's a little easier to get that initial response when you're in an urban area. One, law enforcement response is faster. They have more, more, not equipment, but they have more things available to kind of like talk to you about. And when you're in that crisis mode, okay, we'll stabilize and then we'll have somebody come in. But when you're in a rural area and you're having a 911 response, it could be, an hour. And if there isn't an emergency situation that, warrants 911 and you are just in, severe depression, suicide, juvenile, or a psychosis, that stabilization can be done. But if there's another call and you're working with, 1,000 square miles, you can't just leave that situation as a law enforcement officer. Or you do stabilize and leave. And then the problem is, as I mentioned, Briar, 1-800 number, call it on Monday, maybe you can get a telehealth appointment. And when you talk about the veteran community and you talk about juveniles they're really just trying to survive COVID now, and I think we're hearing from them, they're really suffering. It's that 3 a.m., where you need the help. It's that 3 a.m. when you want to know everything's okay. And that is where we need to really touch and provide them with the assistance. And I don't mean to, say too much, but all of us, I think, are weighing on our heart the suicide rate and the struggles that people all across the state of Washington are happening. And when we talk about mental health providers, mental health access, it is very difficult in a rural area to get access. I mean, very, very difficult. Maybe you can drive 2.5 hours, maybe, and get access, maybe in a 2-week appointment, and if your family has those means available. We are in mental health deserts, and we are in crisis mode deserts too. There is really no help, and I think it's showing. It's showing by the mental health responses that is showing from our juveniles, our veteran community. You're really just seeing a lot of people struggling right now.
Thank you, Madam Chair. Follow-up. As we are considering a multitude of responses in this area, I'm wondering if you can speak to how this bill, maybe in relation to some other ideas, either protects or doesn't protect those mental health professionals that are out there on these calls. Have you learned about that some, and can you share with us?
Thank you, absolutely. So when you do a response with a law enforcement officer, the law enforcement officer, and we do have one today to talk about that, stabilizes the situation. So make sure that you're safe, the mental health provider is safe, the individual is in a stable condition. And then if they do have to leave, that allows that mental health provider to spend that time with the individual that's in the crisis mode. But that situation has to be stable prior to them leaving. And that is, there are pilot projects in the Puget Sound where that does work. And Spokane, sorry, I apologize. And so where those situations do work, where you can step away and that situation is stable. And so that is when we were doing stakeholder meetings, and this is prior to COVID, of course, of quite a few years ago. They said that was the best instead of double car riding, so a 2-man car, because that takes away right now from the low response of law enforcement officers. Once they're stable, then it is a mental health. So what has to happen if we don't have a mental health provider there? That is a hospital situation, ER situation. That may not be a life or death ER situation. It may be a mental health crisis. And a lot of our rural hospitals don't have mental health providers on call. And so if you have to take that individual to an ER or a hospital, then that's a whole different scenario. And law enforcement right now, you're not picking up for, having a bad day, right? Or having a mental health crisis, because that's not a crime. So you're not booking, you're not detaining, and to make it to that level, that's a whole nother scenario where we're not dealing with the actual problem. We're dealing with now a whole side problem. I mean, obviously, if the individual is going to harm themselves or another individual, then yes. But if the individual's in crisis mode, a mental health provider in the area is the best case scenario to have that conversation.